Hello. Today I'm going to take you through our algorithm, including indications and options for instrumentation from a posterior approach in the cervical spine from C3 to the cervicothoracic junction. Taking a look at our algorithm, once we've established the need for posterior cervical instrumentation, we look at the forces that are anticipated. If flexion is the only force anticipated and the lamina or spinous processes are intact, consider a posterior cabling technique. Here on the model demonstrates two of those options, a sublaminar wiring and a spinous process wiring as possibilities. If indeed the lamina and spinous processes are not intact, you must ask, is there rheumatoid arthritis, osteopenia, or kyphosis? If the answer is no, proceed to lateral mass fixation from C3 to C6. If the answer is yes, consider pedicle screw instrumentation. If the option is to proceed with lateral mass fixation versus pedicle screw fixation from C3 to C6, note the difference between the pedicle screw fixation on the patient's left side with the lateral to medial trajectory of the screws compared to the lateral mass screws on the patient's right side with a more medial to lateral trajectory. After that, is there need to instrument C7? If the answer is no, the operation is complete. If the answer is yes, are the lateral masses at C7 adequate for lateral mass screws? If the answer is yes, proceed with a lateral mass screw. If the answer is no, a C7 pedicle screw or a laminar screw is the preferred option. Again, going back to the same model, on the left at C7 demonstrates a C7 pedicle screw, and on the right demonstrates a C7 lateral mass screw. At the bottom, C7 to T1 pathology or high risk for non-union. If the answer is no, again, the operation is complete. If the construct needs to be extended to T1 or lower, the option would be pedicle screws at T1 as depicted here.